appreciate it. Thank you for the invitation, and Dr. Abram and Dr. Aldana. I really have enjoyed the conference thus far, and sorry I can't be there in person. Hearing more about it, partaking even this way, I would say I'd love to be there in person next time. This is really good. I've learned a lot. So I appreciate it. Thank you for the time. I'm going to go ahead and share my screen and start this presentation. And I'll switch this around. Okay. Are you guys able to see that? Or is it sharing?
Yes.
It is sharing. Great. All right. Well, thank you very much. The title is Pediatric Cerebrovascular Disease and Stroke, but obviously for this conference, I'd like to say intervention in pediatric cerebrovascular disease and stroke. And I think that's really the entity here. And you see the subtitle there, Call for Innovation and Current Management Approaches. But I'll tell you that the real word here, the key word is call. I think in pediatric stroke, there's a lot of interest. I think there's intervention in itself as an innovation for pediatric stroke, but I think there's a bigger call for, when we talk about off-label use or on-label use and how we apply techniques and things. I think number one, we just need to get back to the basics for trials to be able to say, are we trying to go forward with the right things in place, the right metrics? So call for innovation is really key here. I'm an endovascular pediatric neurosurgeon. I'm housed at Cincinnati Children's. I handle only kids and young adults in this fashion, but we come across some very interesting cases along the way. I do have a few disclosures. Unlike other speakers here, all of these are unrelated to the presentation in a sense with patents on intellectual property and things. And I would like to thank Dr. Mike Taylor. He's our child neurologist here at Cincinnati Children's, who has been extremely instrumental in continually refining our acute pediatric stroke alert, which is a difficult task in this freestanding children's hospital. It seems like it's a never-ending battle with different disciplines involved. I think there's three objectives that I would say that we want to focus on. One, I just want to illustrate or show you guys some of the current difficulties we have with acute pediatric stroke, intervention in specific. And then second, the application of various management strategies in cerebrovascular disease. I know today is more on the mechanical thrombectomy side or interventional side, but there's also a concern towards aneurysms and malformations earlier in the conference and things. So I would say that there's a various management strategies, and I'll house that more in the idea of what appears to be an acute stroke and ready for large vessel occlusion thrombectomy versus your stroke mimics in pediatrics. And then again, to reemphasize what's been talked about quite a bit here in this conference, which I think is amazing, the importance in molecular and genetic basis towards how we have or conduct management principles going forward. I think in general, this is kind of a general introductory slide. Pediatric stroke burden, 2 to 13 in 100,000 seems quite minimal compared to what was discussed on the adult side of things. But I would emphasize the second topic or bullet point, which is lifelong disability. Talk about 7 to 14% mortality and 70% morbidity when we talk about pediatric stroke in general. So there's a good reason that a lot of drama happens when there's one child that comes in with stroke, and we would say, boy, did we handle this correctly? Could we have done better? Should it have even been handled at all? But either which way, good or bad outcomes, creates a lot of talk or discussion points. And I think that second bullet point gives you reason why. I think a lot of times we think plasticity, neuroplasticity in the young age, or the multiplicity of collaterals gives us somewhat of an alibi to say, these patients are probably doing okay if they already have a small stroke in place. Do we really need to go forward? And I'm going to show you cases in that fashion as well. But presentations of acute pediatric stroke, I would say that number one, getting back to some of the basics here when there's attempts at randomized controlled trials for kids with stroke, we really need to get to categories, and that might help us understand who's really in an acute fashion presenting with a large vessel occlusion, or somebody that can be on the table, or somebody that can have IVTPA. So when we get to the categorization, I would say that Tim Bernard's study in 2012, during the time of trying the TIPS study, which I'll get to here in a second, really talks about the categorization. Is it thromboembolism from cardiac disease? Is it arteriopathy? Is it thrombophilia, inflammatory? So there's a multitude of causes of why a child might present in the ER with very similar acute stroke presentation. So it's hard to decipher that. And one of the biggest problems is getting to the diagnosis and thus a delay in going on to that treatment if it's a hyperacute therapy. So why is it reasonable to even discuss mechanical thrombectomy for kids when we have failed trials to begin with for children? We see that hyperacute therapy really has an extended window, and I don't need to speak to this audience too much on diffuse 3 or Dawn. What it in a summary tells us is that, boy, there's an opportunity here when most kids present greater than 6 hours to even consider getting to a diagnosis and even looking towards therapy going forward. I think that if we look at even thrombolysis, IV-TPA or IA-TPA, and we look at TIPS or the TIPSTERS studies, which are our pediatric stroke studies going forward, these were attempts in 2010 to 2013 trying to look at this idea of hyperacute therapy. And if we look at cases or retrospective studies at single centers, we can even see that mechanical thrombectomy is actually pretty reasonable to consider. It's feasible to do. And when we look at many different centers, there are stroke centers that have handled kids, and even accumulating the evidence even from adults and trying to extrapolate may be reasonable to do this, but in a similar fashion. So in 2019 in stroke, there's considerations for kids where it's number one, very reasonable to consider if there is a disabling neurologic deficit, if there's a large vessel occlusion that can be identified. And it seems reasonable for kids of a certain size, and the decision is made in collaboration, not isolated in rural hospitals and things of that sort. I think if we get to a point where we have a good collaborative sense to understand this is the right thing going forward, it is very reasonable to consider it going that way. And I think that gets to the next point, which is to establish systems and pathways to be sure that we can deliver safely hyperacute therapies. And I think that's really the point that I'm going to talk about here with the TIPS trial coming up next, which is this. So what do we do when we see literature that's out there with case reports on individual cases or single centers that have a number of cases put together? TIPS is a trial where they looked at thrombolysis for pediatric stroke within a certain time period. However, when the trial was open and funded through the NIH and StrokeNet between 2010 and 2013, it ended early. There was one patient that was enrolled of 93 that were screened. So there was an early closure to this, given the difficulty of enrolling patients going forward. I will actually back up a little bit. Let's see if it'll let me do that. Well, it went right through my slides here, but I'll tell you that the last study that I want to show you within this animation here is the results from the Mr. Clean registry. So the idea of looking at kids from this, looking at children that are less than 18 years of age. And what that really gets into is the idea that here are patients that fall into the randomized clinical trial, but have been treated in a prospective manner for this trial, but are all less than 16 years of age. And with that being said, this is great to compare certain kids that have been treated. Now, not many were in this study, only 9 children throughout the time frame here. However, 13 months to 16 years of age, all of them were cardiac based as far as their etiology with thromboembolism. Half of them were LVADs, so in real dire need, and the other half still cardiac, but did quite well when not on LVADs. So very similar to the SPORN study with looking at the Save Child's scenario, where they're looking at both US and European centers that handle children with acute pediatric stroke. So with that being said, there is a basis moving forward. I think in comparison to TIPS, the idea that we're trying thrombolysis and couldn't accrue, there was a lot of scenarios that made it difficult. And one of the things was just having centers that were ready and enabled. There was less than 25% of children's hospitals that were ready to have a stroke arrive and be able to be treated. There wasn't a pathway that was in place. After that study closed, or by the time when they had closed the study and looking at the variables of why that wasn't successful, greater than 80% of children's hospitals or centers were pediatric stroke ready. So having that protocol in place was a key caveat moving forward. And when looking at Tipster, which was an analysis of looking at those patients in that study versus what's been reported, they realized that a lot of things were underreported or not well reported when you're talking about developmental disease. You're talking about kids, whether they're 6 years old or 16 years old versus a 6 months old as well. So with that going forward, development seemed to be a key criteria, and the right metrics going forward were not in place. So a lot of things from the basics of pediatric stroke to be able to move forward with randomized controlled trials, we're just not there yet, but getting very close to those kind of scenarios. What's great about this trial is that it lets us understand that even within a large registry, even looking at randomized controlled trials, we have some patients that are following suit and can do well. So there is an impetus to say that, yeah, I think it's very reasonable to look at cases going forward and to say that if they meet criteria, they may be somebody that can go on to a thrombectomy. But I think in children from other disease states, not just large vessel occlusion, we consider blood and vessel anatomy. So we look at rheology and arteriopathy. That means, what does a blood cell look at from the inside of the blood vessel? Should that be taken into consideration when we talk about pediatric stroke? Because we're really talking about a treatment risk profile going forward. Is it okay to just say they've got great collaterals and they've got neuroplasticity? Maybe they have a small stroke, but I think they'll do well past that. How is it possible that we can look at the blood cells and their interpretation, or arteriopathy? So I'll give you an example. A child comes in with sickle cell disease, but showing us a large vessel occlusion. Should they go forward or should they not? It makes it very difficult to say what that risk profile is. Is there an association with moya there in that child? And is that something that we can get to right away with CT and CT perfusion, or should we be looking at MR and things of that sort? So that gets me to point B here, which is stroke mimics of a thrombus associated with LVO. And then point C is biomarkers in kids. If it's that difficult to get to a diagnosis and to do that quickly, should we be looking at other biomarkers that take into account things like blood, so rheology or arteriopathy? So one thing that we're looking here at Cincinnati, both here at Cincinnati Children's and also at University of Cincinnati, is the idea behind quantitative arterial torch velocity. Does that index tell you anything towards kids with the possibility or the enablement of having a stroke, or enablement of even doing a treatment that can be successful going forward? I have the luxury of being surrounded by a multidisciplinary team and being able to look at different disorders that may present with a large vessel occlusion. So it makes it easier to get to definitive diagnosis, at least a bit quicker, but still a long period of time. But in general, it still comes down to the question of to treat or not to treat. And here are the challenges that I'd like to identify here as one of the major concerns, which is delay in diagnosis. Stroke mimics. Is that why we can't get to that diagnosis right away? Or is it social standpoint, when a child can't advocate for themselves to tell you what their symptoms are and for how long? Age, size to treat? I would argue that, yeah, I think that's a very important point, but not as important as the two topics above that. I do think expertise in a comprehensive stroke network is important, because there are a lot of times that, and we've seen them referred in where somebody undergoes a thrombectomy that probably did not need to, and it was focal cerebral arteriopathy or other scenarios going forward. Coagulation status, all things that matter, but at the end of the day, really only 2% of AIS children receive TPA in these studies going forward. So it's really hard to identify these correct patients going forward. At the end of the day, we'd all agree that goal of intervention is to prevent stroke. So I only wonder if we should be adding in, and this is what we think of in pediatrics, vessel disease recognition. So in general, I have a summary of multiple cases, and I've starred 3 of them that I think are important for today's talk and things. So I'm going to start out with the first one, and I kind of reordered these for this today, just hearing about how this conference was going and things. I thought this might be the most beneficial route going forward. So case number 2 is an 11-year-old with a past medical history of rheumatic heart disease requiring a mitral valve replacement in 2016, consistent lab draws with INRs that were oscillating between subtherapeutic to supratherapeutic and rarely perfectly in the middle. Had chronic left-sided weakness that's been ongoing for greater than 5 years, working with occupational therapy and the meds listed, but he woke with a facial droop, significant left-sided hemiparesis, and a CT had performed at an outside hospital. And what I'm not showing you right away is that this is during the COVID pandemic. This is during the shutdown in 2020. So it made it really hard for patients to advocate for themselves, number one, and number two, for a child to advocate even further with language barriers and for their families to say it's okay to go to a hospital setting. But despite that, this child presented multiple times and likely for things that we know of now with multi-inflammatory syndrome a priori, a few weeks prior, and then coming forward with 2 ER admissions before getting this head CT. And the CT, you can see here on your right picture, you've got a hyperdense MCA, you've got ischemic stroke, insular region, deep brain, an aspect score of 5 and an NH stroke scale presenting at 8. The CT angiogram really discusses going right at that thrombus, so large vessel occlusion, but there was great collaterals and there's a stable infarct because we really repeated the CT, CTA moving forward as they were trying to be transitioned from the outside hospital. And when we look at this, we'd say, boy, I see that distal MCA. It looks really good. There's good collateralization. I see the ACA as well. I see a PCOM. I think there's good sense that that stroke may have occurred and we may be done. Do we need to go forward? And that becomes a question. Is there evidence to back this, especially when a lot of the things that we do in pediatric stroke or cerebrovascular care are off-label? Or in some cases with certain devices not indicated for pediatrics. So it makes it very difficult when those kind of labels are even put in place. We have a clot burden score of 4 in this case, a collateral grade of intermediate. And then we went on to a CT perfusion, but I'll tell you, there was a lot of discussion even to go on to this because during the pandemic shutdown, even when you're in a regional or a comprehensive stroke center, and I think very highly of our Children's Hospital and the stroke system that's set up in place to be in collaboration with UC, even the perfect system breaks down, especially in things like a COVID pandemic, and the lessons we learn from that can really move us forward. But we depended on an ambulette protocol to help move us for a CT perfusion when an MRI was not able to be performed because of the heart valve replacement. When we go forward with a CT perfusion, we see a great mismatch ratio of 6.7 and 87 cc's, thinking going forward that there's an opportunity to treat here. We don't think that this is enough. There's a lot to lose if we leave this alone. So going away from time-based to tissue-based was very helpful here, because what I didn't tell you is that this patient was last known well the night before and awoke, and I'm going to show you the time frame, at 6 in the morning with this stroke. And by the time they were ready to be on the table, we're looking at an average of 17 hours, between 14 to 21 hours later from that last known well. So how do we go forward with considering endovascular or thrombectomy going forward? Well, 139 cases of pediatric EVT, a scientific statement, evidence to date would suggest level C, class 2B recommendations. And I think even with that, we would say that it's, again, very reasonable and in a comprehensive center may be appropriate to look to go forward if you think it's necessary. And I would say right off the table, when I hear discussions of should we just skip the CT and go from, or CTA, or MRI and go from that CT to the table to look at our angiography, that may have been helpful because here our CTA shows us great collateralizations distal to the MCA and our ACA well there. But on the first run on the table here, I didn't see any ACA collaterals. I don't see the distal MCA. So obviously a change, and right off the bat knew that we were going in the right direction. So very proud that we went and moved forward there. As far as access, this child was 11 years, so very easy to get access. I use an ultrasound guided dermatotomy technique, very similar to what you'd use for transitional dilators or radial access sheaths for younger children. We designated this as a level A surgical emergency, even though we were already delayed coming in. We didn't want to take any more time off. So we went forward with a direct aspiration technique. And doing this, we would see, despite tortuosity being a concern, not in this case, and a lot of times with the cardiac patients I've had to deal with large vessel occlusions, sometimes that clot can be very sticky, chewy, even somewhat calcified or hard. So that makes it somewhat difficult. Here was not the case. And even right now, we're looking into the clot composition from a sense of, is this more COVID related? What can we learn from the fibrin composition and things? So that being said, the thrombus was extracted and the patient did quite well from this. You can see here TQ3 revascularization, one attempt, did quite well. Mild spasm that did not need to be treated, did very well. And I can see the ACA collaterals and distal MCA quite nicely. If we look post-operatively, we can see that really everything was essentially stable and things look good. He did quite well being on post-op day 1 with aspirin, transitioning to or adding in Coumadin, and then going on to be discharged home on post-op day 5. Short-term follow-up at 4 weeks, he was back to his baseline with resolved facial droop, a slight leg paresis that he's always had, working with occupational therapy. And even now, years later, he's back to playing soccer and also teaching on the sidelines and things. So doing quite well. I'd say going back, what did we learn when this was somewhat of a difficult case in decision-making and things right off the bat? You know, at the outside hospital, they're associated with a local group that handles thrombectomies and has a local stroke network there, somewhat outside of our network. And the decision was to maybe delay or not treat. And then the decision was to call us directly here at Children's to move forward. And appreciative that they did, because here we were able to get a great result, but not an easy decision to make. And you might say, well, really, how much did the COVID delay or COVID pandemic really delay things? Well, if I look at pediatric EVT and COVID, there's 3 cases that were reported that clearly describe the case in essence on each of the cases. One was associated with multi-inflammatory syndrome, very similar to this. COVID-19 with respiratory symptoms, an outpatient that recovered prior to their presentation with an acute stroke, meaning 3 weeks prior. And another that was identified with COVID-19 positive on the stroke presentation on arrival. So all is well here with the idea that COVID-19 was there with symptoms prior that seemed to resolve. And this is all prior to vaccination status. We didn't have great COVID-19 tests to begin with at that time. But here's our timeline to give you an idea and where the decision was being made. And this is why I purposely put this towards the end of this case, was the idea that we're at an outside hospital on arrival at 7:02 a.m. Last known well was 10 p.m. the night before, but really this patient presented a few times over the last several weeks prior to that, likely because of COVID. Wake up stroke at 0600 outside hospital, ED 0900 with a concern of evaluation for stroke. CT head at 10:02, discussion, review and accepted, arrives to Cincinnati Children's. Difficulty with understanding, can we use our MR, can we not? And then had to be ambulated over for a CT perfusion when the decision was made to go on with a perfusion sequence rather than just going off the CTA. And with that being said, you'd see that significant time delay from 1:40 to 6:09, and it was a killer to sit there and wait and wonder why this patient is taking so long, when I feel, and Mike Robinson, who's here in the audience, would tell you, I could just push the patient across the street. Why did we have to wait for this? But this really gets to the point of protocols. And I think there's a recent paper here in JNIS where we talk about what did the COVID pandemic do to us when we look at comprehensive stroke centers versus non-comprehensive stroke centers. We take a bigger impact in the comprehensive centers. And it seems ironic that that would happen. But when we have such a protocol and we're so dependent on some of these protocols, sometimes when there's a change and we're not notified of it or know of it, it becomes a real problem. And I love the idea of how you guys have a coordinator there that helps with moving all these bits and pieces. And I think from a children's perspective, that's probably one of the next systematic steps that we need to get to, not just being pediatric stroke ready, but have a coordinated network that way, not just a network. So finally, groin access at 7:18 p.m. and the results that were shown. I would say with this case alone, the challenges that were identified here was that number one, delay in diagnosis was a real problem going forward. I think we did not think that there was a mimic. We thought that there was this large vessel occlusion. It was just the idea of should we go forward with that diagnosis or not, and delay in the treatment. And part of it's just getting to that expertise to be able to make that decision to go forward. I think in general, specifically, the regional transport protocol was our biggest problem moving forward. I think that could have helped with timing, but at the end of the day, whether it was 6 hours or 7 hours versus 17 hours, I think we still had the right to move forward, and I'm glad that we did either way. So the things that we could definitely improve on, and I think that pandemic shutdown really gave us an opportunity to say, how can we refine our system moving forward from a stroke net perspective? I'll go back and say that, sometimes not all cases are so obvious with large vessel occlusions. I'm going to go to this one, which is a 4-year-old with 2 months of repetitive outside hospital ED visits before they finally got a CT scan and some concern for hypodensity. And you can see here on their MRI that they went on to get, after being admitted, a number of small collaterals and things, and they weren't really sure why these TIA events were happening. So then they called us and referred down, and we get an MRI and MR perfusion with hyperperfusion in certain areas within this scheme of multiple vessels. And we also see hypoperfusion in other areas. I put them on the table. We go forward with looking at what this may be, and we see puddling of contrast as a keynote term, and we even see transdural collateralization with our external carotid artery and things, and we'd say, boy, this looks very akin to cerebral proliferative angiopathy. And that's exactly the case. We moved forward and said, boy, here's one where there was consideration at the outside hospital and the ED, where the interventionalists had thought about putting them on the table for a possible stroke, a 4-year-old with concern, but on that CT and then MR seemed a bit odd. So glad they were able to get the MR and then make the phone call to not put on the table for that reason. So stroke mimics happen even with the same acute presentation going forward. So here, I think, learning from this case, regional collaboration is very important. I think having that comprehensive stroke network saying, I think, Dr. Hanal, you made a mention of, maybe more interventionalists need to be at one comprehensive center rather than having multiple centers with multiple interventionalists everywhere. That might be the parallel approach. And I absolutely agree. I think from a pediatric standpoint, I think that's what we're seeing here. A greater collaboration regionally to try and get to one center might be the way when there's an opportunity for more time to get to the right diagnosis. And I'd point out that even social delays were part of the issues here. When you have a 4-year-old that can't advocate for themselves, part of it is family awareness and understanding what happens. We don't think of stroke in kids, at least for parents, not to the level of knowledge that we do for adults. So that can be very helpful going forward. On a contrary, and I know that I've got just a few minutes left here, I want to go to this video gamer that we talk about, or loosely coin him with, and say that here's acute left-handed paresthesia, neck pain, headaches, and a very similar scenario presenting to the ED at an outside hospital on the adult side. Had a CTA, and it was even put on the table with that CTA concerning that there might be an aneurysm associated. So they did a digital subtraction angiography and identified cerebral proliferative angiopathy. And purposely, I put this case here to mirror the other case. And to know that even with this acute presentation that sounded like an acute stroke, here we have a hemorrhage, a large temporal hemorrhage. And really, this patient presented 4 weeks prior, should they say 3.5 weeks prior, with a small subarachnoid hemorrhage within the parenchyma, concerning much akin to a trauma. But this is a video gamer. He wasn't out, he didn't have any trauma, things of that sort. It was spontaneous and identified with cerebral proliferative angiopathy. He was transferred here, hospital day 4, for further acute care. Using cross-sectional imaging, I agreed that there was an aneurysm. And moving forward, instead of revascularization, microsurgical revascularization, like the other patient who underwent, this patient I took to the angio suite and did targeted embolization of the aneurysm, knowing that there was a mild spasm in the traversing vessel that goes on to this small aneurysm, treated this area that was within the level of the hematoma, and has done well without repetitive hemorrhages, and we're currently following now long-term. So I think there are definitely opportunities to use intervention in pediatric stroke for not just large vessel occlusion, but even for other entities of stroke as well that we see in kids. And I think the idea of intervention is in general for pediatric stroke is novel or innovative. but we have a lot of room to move forward. So that being said, I'll go right to my concluding slides here, which are the difficulties in acute pediatric stroke intervention really go into a number of things that you guys have talked about, where a lot of it's still awareness in kids. I think it's not only important to incorporate our child neurologist and our pediatric trained interventionist, someone that has familiarity with children to be able to do this, but also our diagnostic neuroimagers, our diagnostic neuroradiologists, to be able to say that we want to go on to that MRI or CTA. It's not so easy in a children's hospital to make that decision or pull that trigger. There'll be a lot of discussion both ways. I think there are very few standard outpatient cases that come into the ER. Actually, most of them are coming in already admitted in the critical care units. So coordinated regional comprehensive care is really important. So I stress the idea behind coordination, which I loved hearing about a lot in this conference. I do think neuroimaging, we have a lot to work on as far as biomarkers, from collateral evaluation to tissue-based approaches with perfusion. Very much is that a key strategy for us here. I think the selection criteria really, we need more biomarkers. From arterial tortuosity index is one that we're looking into. But at the end of the day, I would say the call for innovation really move forward with at least a call for pediatric approved interventional devices, or at least taking the label of not approved for pediatrics off devices. I think that can be very helpful moving forward. At the end of the day, Dr. Aldana and Dr. Abram, they both know they've been here to our conference that we host out in Aspen. It's a little plug for our pediatric specific cerebrovascular disease and stroke conference out in Aspen during the summertime. Ironically, it's beautiful, it's fun. The next conference is in July, so I encourage anyone interested in pediatric stroke and cerebrovascular disease to try and come out there and join us. But with that, I'll end and say thank you very much for this opportunity. I very much appreciate it.